them. So looking at neck, and here they want to know, is there a range of motion limitation? If there's no limitation, you would write 0. If there's a limitation on one side, you would write 1. If there's a limitation on both sides, you would code 2. Then they want to know for the neck again. So this is a range of motion limitation actively or passively if they have a limitation. Then the voluntary movement loss would be the active part. So is there a limitation? Sorry, I'll just start over for a sec. Range of motion limitation would be passively. So if the resident can only lift their arm this high, they would have a voluntary movement loss, which is the active part. But if you can then lift their arm up to full, so they have full passive range, they would have no range of motion limitation. They have a voluntary movement loss, but not a range of motion limitation. Partial voluntary movement loss means they have partial limitation on one side. So partial means they have a limitation on one side or part of one side or part of both sides. So take, for example, somebody who's had a stroke and they can't move their arm at all, but they've got full range of motion here. That's considered, they would have range of motion limitation probably on one side because they've probably lost passive range on that paralyzed side. If they're a rigid paralyzation or a tone, they've got tone. Voluntary movement loss would be partial and not full because they still have movement on half of their body. So it's only a partial loss because they've got the one side that they can't move voluntarily. If, what would be another example? Let's use the stroke example again. So if somebody had a stroke but they had a flaccid stroke of this arm, so they have no active movement in this arm, to code for range of motion limitation, which is the top one, if you can move that arm fully passively, they have no range of motion limitation. But voluntary movement loss would still be partial. Even though they have no active movement whatsoever, it's still partial because their other side is full. If somebody has arthritis, we see this a lot, they may only be able to lift their arms up this high. So that's a voluntary movement loss. If then you try to lift their arms up passively and you're limited because of pain or tightness, then they would have a range of motion limitation on both sides, and voluntary movement loss would be, again, partial because they have some active movement. The only time they can have full voluntary movement loss on both sides is if they have absolutely no active movement and they're limited passively. You may want to consult the RIMDS manual for a further description. They do have a full page that describes it. I was just trying to make it a little bit easier, but if it's still not very clear, you might want to double check in the RI manual. Then you have to code for arm, so that's shoulder and elbow together. So if they have a limitation in their shoulder but their elbow is full, they would still have partial loss and maybe one-sided loss. The hand includes wrist and fingers. The leg includes hip and knee. The foot includes ankle and toes, and then there's other. So because they have neck and then they don't have anything else, if somebody has a severe scoliosis or kyphosis, I would mark thoracic spine, and then I would code for the limitations. If they have a significant kyphosis or scoliosis, I would mark that there. So that's the range of motion. If you have to do both G3 and G4, there is a form for that as well, and this is what it looks like. And it's the same again on the front and the back, so you've got 4 on the front and 4 on the back. You've got lots of room for coding, so you can use the same sheet for 2 full years. And honestly, if your home's not asking you to do G3 and G4, don't search for more work for yourself. My personal opinion is that nursing should be doing the G3 and G4 coding because according to RIMDS, the licensed nurse has to do an assessment quarterly and do a care plan and assign the treatments to the nursing staff on a quarterly basis. If they've got range of motion or walking or transfers as part of their restorative care program under nursing rehab, they're supposed to be doing a quarterly assessment that the resident still needs those interventions, and I think that G3 and G4 are the perfect assessments for them to do and code on a quarterly basis. So for some reason they still feel that physio is the people that should be doing it, and therefore if your home hasn't asked you to do it, don't search out for extra work like I've already said. Let them continue the coding and just ignore these forms in your binder. So as you know, for all of our residents, whether they be in nursing homes, retirement homes, or community setting homes, all of our residents are guaranteed 100 visits. The OHIP fiscal year is from April 1st until March 31st. So when April 1st rolls around, the resident has 100 visits as long as we have a signed medical referral, or in a nursing home a signed referral by an RN. They're allowed those 100 visits, no questions asked. Many of the residents that we work with, I would say the big majority, do need extra visits, and so the ministry has allocated an extra 50 visits that the residents are allowed to have, as long as the physiotherapist can show objective proof for the need for those visits. I would say in most cases all of our residents would benefit from those extra 50 visits, which gives them a total of 150 visits per year. When you're looking at 150 visits per year, it's basically 3 treatments per week for the entire year, with the exception of a couple of weeks. Some of our residents may need care Monday to Friday if they're on a walking program or on a chest physio program, or if they've had a hip fracture and they're back from the hospital, or they're a new resident. They may need 5 days a week care for a certain amount of time, and that's okay. Even if they're on a walking program and they have daily walks, like Monday to Friday walks, 5 times a week for the entire year, it's okay. We need to give them what they need. However, we're only paid for 150 visits. So, once we get to 100 visits, no questions asked, we have to have certain paperwork in place in the residence chart before that 101st visit is billed to the ministry. In the past, we used to have to submit that objective proof to the ministry, wait for them to approve the extra 50 visits, and send that approval back to us before we could continue treatment with the residents. It was a ton of paperwork. It was long waits for residents. The ministry saw that it wasn't the best system, so what they've said now is, as long as we have the paperwork in place before that 101st visit is billed, or that first extra 50 visits, then it's okay. So we have to have the paperwork in place before we bill that 101st visit, or that first of the extra 50 visits. That paperwork is all within this form that's called the Physiotherapy 85V for 85th visit summary and referral form, and this is what it looks like. It's a one-sided form. Basically, we have the top part of the form up to the grade area here. So all this top part of the form is the objective proof that we feel the resident needs continued physiotherapy, and the new referral, because we need to get a new referral signed for those extra 50 visits. This is easy in a nursing home, because once the form is filled out at the top, we can just ask the RN to sign the new referral. This becomes the new referral that's in the residence chart as the new referral. In retirement homes where the MDs visit regularly, it may not be so difficult. However, not all doctors visit the homes regularly. In community homes, they don't really visit all that regularly either. So in retirement home and community homes, there is going to be a need to fax this referral, this summary and referral sheet, to the doctor, and it cannot be a nurse, it has to be the doctor, for him or her to sign it and fax it back to us. Let's just look through the form here for a moment. So at the top of the form, again, we have the resident's name, perhaps the room number, date of birth, health card number, the name of the physiotherapist, and the date of the reassessment. The reason it's called the 85th visit form when they're allowed 100 visits is because we want to have some warning that the 100th visit that they're allowed, no questions asked, is coming forward. And so Coligo, when the 85th visit is billed to the ministry, Colago will send an email to support office and to the physiotherapist who's the billing physiotherapist for that resident. Even if the PTA is the one entering their stats and the treatment is billed and it's the PTA that does it, it'll go to the physiotherapist that the treatment is billed under. There's a warning email that is sent to the physiotherapist and to the support office saying this resident just had their 85th of 100 visits. You'll see it in the subject line. You have to open the email to see the date that the resident had that 85th visit. The PTAs are usually the ones that keep track of this, so I would ask when you open that, because the PT or the support office may be forwarding those emails to the PTAs, when you open your email, just write 85V December 1st. That way you have a record of when the resident had their 85th visit. Just write it at the top of the form. Then you take this form, the resident 85, 100, 150 visit tracking sheet. This is what it looks like. It's the same on the front and the back. When you open that email and you write the date on top of the summary and referral form, you then write the resident's name on the tracking sheet and the date of their 85th visit, which is inside the email on the first column there. You would then alert the physio to the fact that they have an 85th visit form to complete. The physio takes this form. They're going to look and see, okay, the resident had their 85th visit on this date because the PTA has written it at the top. In a nursing home, they'll look at their RISE schedule. In retirement and community homes, they'll look at their resident reevaluation sheet, the tracking sheet, to see when did they last reassess the resident. If you've seen the resident within the last 3 weeks of their 85th visit, why not use that last reassessment to fill out this form? Now, don't just say see reassessment dated whatever. Here, actually fill this out because we need to have that objective information on this form according to the ministry guidelines. So you're going to fill out their range of motion and strength, their cardiopulmonary system, any Tinetti, ambulation, tug, unipedal stance, 3-minute walk test results. You're going to fill out what they've shown improvements in or maintained, what they have continued attention or need for attention for, and what the treatment plan is. Okay, so you're going to fill this out. Again, if you've seen them in the last 3 weeks from their evaluation, their 85th visit date, you've seen them 3 weeks within that date, you can use the information from that assessment to fill out this form. If you have not seen them, let's say it's been 2 months since you've seen them, you'll have to go see the resident again and just do an 85th visit assessment to be able to fill out this form, to get it faxed to the MD if you're in a retirement home or a community home, or to bring it to the nurse if you're in a nursing home to get the new referral signed, which is just the bottom part here. Okay. If you see that you get the 85th visit, it's December, well, let's say December 1st, that you get the form that they've had their visit on December 1st. If you see that you're due to reassess the resident the week after or 2 weeks after, you can wait to fill out this form when you see them in 1 or 2 weeks. The only thing is, if you have to fax this form to the MD to sign and get it faxed back, you may not want to wait 2 weeks, because what happens is, if you, let's say they had their visit on December 1st and you're now December 4th. If you're supposed to see the resident on December 10th, you fill out the form, you fax it to the doc. By the time the doc faxes it back to you, you may not have it in time in place in the chart before that 101st visit is billed. So if you have to fax the forms back and forth, it's really important that you see them as soon as possible after that visit date. And what can happen is, if you get their 85th visit was December 1st, it's December 4th, you go see the resident today, they were only due in 2 weeks, well, you've seen them for their quarterly reassessment. You don't have to re-see them in 2 weeks. You can just bump their quarterly assessment up a little bit so that this counts as their quarterly assessment as well. Okay?